Good afternoon. Welcome in once again to Evergreen Talks, a production of Evergreen Family Medicine. I'm Brian Prowitz, your host, and on the Evergreen Talks on the second Thursday of the month at 4 o'clock, we come to you live on Facebook and also on YouTube for conversations with our physicians and providers and specialists that present topics that matter to you. And we always encourage you also to visit evergreenfamilymedicine.com for more information about our topic today, or if you want to learn more about the providers and all the services available at Evergreen Family Medicine. But today we welcome Dr. Emmanuel Okenye to Evergreen Talks, and we are going to be hearing from Emmanuel today about chronic kidney disease. It's nice to see you again, Dr. Okenye.
Nice to see you, Brian.
I'll be standing by while you give us the presentation today. So have at it, my friend.
Thank you. Thanks for having me, Brian. It's such a pleasure to be here today. First, I want to say thank you to all our patients and everyone that makes Evergreen what it is today and how successful we have been over the years. Thanks to all my co-workers and all my co-physicians and all our staff. We do a great job here at Evergreen. Also want to say thank you to all my attendants that trained me, that made me who I am today. Dr. Shoemaker, Dr. Sams, you all just, made me really develop into my, learn a lot about kidney disease. It was just such a wonderful time training with you all at University of Kentucky. So today we're going to be talking about, the topic is Yikes. My chart says I have chronic kidney disease. And I'm going to just be sharing with us some of the risk factors. I'll talk about the causes. I will talk about some of how to diagnose chronic kidney disease. What we look for as physicians in patients that have chronic kidney disease. Finally, I will also be talking about some of the foods. I'll talk about some of the just how just what to do when you find out that you do have this disease, and then we'll just answer questions. Okay. All right. Let's go. So first first things first. What are the kidneys? Right. That's like let's go down to the basics. So we know they're a pair of organs. They're 4 to 5 inches long. They are located just deep deep in the just in the underneath the the rib cage. What do they do actually? They help to filter the blood, right? So we know that the blood pretty much your effective blood volume pretty much goes through the kidneys, and the idea is that it gets rid of all the junk, and it then eventually the idea is to get rid of the waste products and then retain the good stuff, right? So byproducts like urea, like certain electrolytes, things we don't want in the blood, or things that we have too much of, the kidneys do a good job at regulating that. And I think that's actually one of the most interesting aspects and one of the most exciting parts of the kidney actually is not just that. I know we think about peeing, but the whole idea of even getting into for you to get blood and then turn it into eventually get to urine. It's a very beautiful process that occurs in the nephron, and each kidney has over 1 million of them, and they help to microscopically filter the blood, and they do it very efficiently, actually, very, very efficiently. And it's amazing how we're able to function, with a pair of those. Of course, so removing waste products, filtering, and then regulating electrolytes. But in so doing, you're also regulating blood pressure, right? So because when you regulate the electrolytes in the blood, then you're regulating sodium, potassium, and chloride, all of that. That actually helps to regulate your blood pressure. And so you ask, how do certain medications, that you take work? And some of your high blood pressure medications, for instance, work at the level of the kidneys because, because of that important function that the kidneys have, helping to regulate blood pressure. All right, we'll go to the next slide. So, what is chronic kidney disease? We know that 1 in 7 Americans have this. Very important to actually distinguish between acute and chronic kidney disease. So, of course, acute meaning something that had just happened, a very sudden insult. Chronic meaning something that has been long-standing. And there's a key, there's a temporal relationship between that, between those two things. When we talk about chronic kidney disease, we're talking about 3 months, around 3 months, at least 3 months, of a trend, of decreased quick kidney function, as opposed to the acute phase where something had may have just happened in the last few days. We look at the numbers and we say, okay, well, this is just a new insult. We'll call it acute. Now there's one part of it that is kind of in between acute and chronic, which we sometimes call subacute. That's a little vague, but really it's not acute, but it's not up to 3 months. So we say, you know what? Yeah, it's chronic. It's subacute. So it's neither of the two. So that's a little nuance. But for the most part, chronic kidney disease, you think about 3 months of kidney decline, and I'll explain it more in subsequent slides. But eventually, what then the idea behind why do we want to know if you have chronic kidney disease? Because of the complications, because eventually it leads to kidney failure, and patients sometimes have to be on hemodialysis. And just think about it, right? If the kidneys are not doing the function that we just talked about, then you're going to have just toxins building in the blood. You're going to have difficulty with regulating blood pressure. You're going to have difficulty with doing some of the major functions that the kidney does. So it's actually very important to keep up with this. Okay. Next slide. So again, what are the most common causes? Okay. The first two that comes to mind is poorly controlled type 2 diabetes, or diabetes mellitus, whether type 1 or type 2, and high blood pressure. Right now, you may ask, how does type 2 diabetes, how does diabetes, for instance, cause kidney disease? And I think it pretty much it goes back to the fact that even though you have sugars in the blood, of course, with type 2 diabetes, you have a bunch of sugars just in the bloodstream, right? And sugars, of course, they float in the blood, they get to the kidneys, and many times the kidneys are able to handle a little bit of sugar at a time, but once you start having this constant insult, this constant bombardment of sugars coming in. Now, what do sugars do in the bloodstream? Sugars basically they tend to affect the vascular endothelium. They cause plaques to build up in the vascular endothelium, not just in the kidney, in the arteries in the kidney, but even the arteries everywhere else. And that's why we talk about patients that have diabetes having more increased risk of heart disease, having increased risk of strokes, because of course, in the small vessels in the brain, those smaller, tiny little bitty bad vessels are the most susceptible to those plaques, that diabetes causes. And so the same thing happens in the kidneys. Now think about that, right? The kidney arteries, those arteries are also small, tiny. Eventually those sugars, of course, affect the endothelium, but also affect even the filtration apparatus in the kidney. And when that happens, just think about it. Think about a sieve that is broken, like a water sieve, a filter that is broken. What happens is that you start to lose things that you should not be losing. So like, things in your bloodstream that you should not find in your urine starts to show up. Why? Because the filters are bad, are messed up, are bad. So for instance, you have things like big protein, proteins, big substances like proteins should not be in your kidneys, but because the kidneys are defective, or have been eroded, or like compromised by type 2 diabetes, and some of the complications that comes with it, it causes those proteins to start to show up in the kidneys. And when proteins start to show up in the kidneys, in fact, that's actually one of the first early signs that we begin to know that I think this diabetes is actually creating problems in the kidneys. We need to do a better job at controlling your diabetes, because now, as your doctor seeing you in the clinic, I'm telling you, listen, I'm beginning to see proteins in your urine. That's not a good sign. And of course, the more proteins you're seeing, the more destruction is going on, and so forth. Something else is high blood pressure, right? High blood pressure, for the above mentioned reasons. I mentioned earlier how the renal arteries are very important in regulating blood pressure, but sometimes you can have excessive blood pressure whenever you have just very high blood pressures. It causes vascular vasoconstriction, and that actually reduces the blood flow effectively to the kidneys, and that can create problems. Now, there are other causes that we tend to think about, things like glomerulonephritis, which is a complex set of conditions that, caused by inflammatory, conditions, or caused by infections, or caused by, um, viruses, parasites, that actually affect the kidneys, by themselves. Things like polycystic kidney disease, which is a hereditary condition, can also affect the kidneys. The kidneys develop a bunch of cysts, and many times it eventually leads to kidney failure, and that's one of the other causes. Lupus is another one that it's that we tend to see some, but there are different stages of lupus nephritis itself, but yeah, affects the kidneys and causes eventual chronic kidney disease and kidney failure. Cancer, we talked about that. Renal cell carcinoma is a very good example. It actually it affects the kidneys and invades actually into the vessels, and it can be kind of aggressive. And so, very important that we also consider that as a common cause, as a cause of chronic kidney disease. Now, certain medications, we kind of alluded to that earlier, about medications that help to control blood pressure. Now, we think about certain medications like your common ones, like lisinopril, which you take for blood pressure. Sometimes can help, sometimes can affect the kidneys negatively. You think about other medications like lithium, for instance, right? Lithium is one of those medications that we use for, in patients with bipolar disorder, but by itself it also affects the kidneys. It affects the concentration abilities of the kidney, and of course, causes a lot of, increased urine output and all of that, and then patients eventually lose, they begin to lose kidney function that way too. Other medications would include things like your cancer medication, like your, cisplatin is one of the common ones for used in cancers, in cancer patients, chemotherapy. It can also cause, it's also nephrotoxic. Basically, it's toxic to the kidneys, and so we tend to look out for those medications too. There's several other medications that we can begin to also kind of think about. Of course, antibiotics is another big one. So you can have some renal toxicity too. Um, you know, Something else that I forgot to mention also is contrast, right? So you have, patients that, you get exposed to contrast. You have to go to the hospital to get some kind of imaging study done. You get IV contrast. Sometimes it can affect the kidneys. Now, many times this is kind of, it doesn't really affect it like chronically, but over time, multiple exposures can create problems. And now we're learning more about, MRI, gadolinium contrast, induced sclerosis. It can also affect, basically cause chronic kidney disease too. Other things like environmental exposures, to contaminants and occupational, stuff like lead poisoning, and all and the likes can cause chronic kidney disease too. All right, next slide. So risk factors, we mentioned that, briefly earlier. Diabetes is a risk factor. Blood pressure, liver disease is another risk factor that I haven't mentioned. Heart disease, obesity. So all these are the things we kind of look for when you present to the clinic, and we are, in the in thinking, along these lines, and trying to figure out, if you're at risk. Also, family history of kidney disease. If you came into the clinic and say, "Hey, doc, my parents, my dad had, polycystic kidney disease, or my dad had this," I begin to kind of, that raises my level of suspicion. Also, if you're over 60, the older you are, of course, the more mileage the kidneys have got, like so, your kidneys are going to be a little bit more susceptible to acute and chronic insults, than, say, much younger patients. Of course, there are ethnicity differences. African Americans, at more at risk. Hispanics, Native Americans, of course, Asian Americans, more at risk. They are more at risk than, say the white population. Next slide. So, symptoms. Now, I put the slide here for a reason. Technically, it's not because, you know unlike many diseases, right? Kidney disease is not one that when you see a patient, you start thinking, oh my goodness, that patient looks like they have kidney disease. I mean, for you to think that by just looking at a patient, most times the patients are way advanced in their disease course. For instance, the patient is probably already needing dialysis. And so because of that, they are really, they are just their volume status is just so huge. I mean, they are like they have all this volume everywhere. They look, for you to get to that point where you can just look at a patient and tell, they're usually really advanced. So the point of symptoms is not necessarily, it's just so you just kind of know how vague the symptoms are really actually. So for instance, you have itchy skin, right? I mean, there are many conditions that causes itchy skin, like from liver diseases to all kinds of different things, like allergies, muscle cramps, many conditions. That's not really, very specific. Feeling weak and tired, a patient comes and says they're feeling weak and tired. I'm not gonna be like, oh, you probably have kidney disease. I'm not gonna say that, because you just don't know for sure. It's very vague. Feeling hungry than normal, sick to your stomach, throwing up. Now think about it. Some of these symptoms actually sound like, some stuff you would say in pregnancy too. So it's again very very vague. Swelling in the legs and ankles and feet. Well, could that be, heart failure? Could that be liver disease? It's really hard to kind of know based on that symptom. Urinating more or less than normal. What does that even tell me? Nothing. By just looking at that symptom, I don't know. Foamy, frothy, bubbly urine, just means there's protein in your urine, but the protein could be from other things that can cause protein in your urine. Doesn't really specifically say, tell me that there's something going on with you. I mean, it tells me there's something going on with your kidneys. I would say if you start to see protein, but most times just the frothy and foamy urine, there could be other reasons. Trouble catching your breath and trouble falling asleep, again very vague, many reasons to have troubles catching your breath, and so really doesn't help you as much. And that's why in that in and I do it, and interestingly, those symptoms are many times not present in the early phases, right, in the early stages of kidney disease, but that's when we want to catch it, right? So next slide. So that's why we have to do tests, right? So we have to do tests because you're not able to just like look at a patient and just say, okay, yeah, well, yeah, they must have this. So this is one of the situations and times in medicine where we actually have to do testing and get screening tests. Check your chemistry panel is one thing we look at, and when we do that, we're looking for a number. We're looking for something called the GFR, and that GFR is what basically gives us a clue. It's a very complex set of numbers that comes out to help us calculate that. But thankfully, we don't have to do that during every office visit. We're able to get that number from getting the labs, and the computer spits it out, and that basically gives us a sense of um, what your kidneys are doing basically. Now think about it. It's not usually accurate sometimes in patients that are young, less than 18, pregnant patients, also very overweight patients or very muscular patients. It's not the most accurate. Now, urine tests, we tend to do, we check the amount of protein in your urine. Of course, it makes sense. If the kidneys are not doing their job, the first thing we see is proteins. We want to see if there's proteins in your urine. Now, many times we'll sometimes get, sometimes we'll get a more specific test, like a more like the 24-hour urine test. We sometimes get that, to see a little bit more, get more information. And then also imaging test is something we do. Ultrasounds, we're looking for for cysts in the kidneys, or we're looking to see how something we call echogenicity, like how much light penetrates it. This gives us a sense of what the kidneys are doing. They're normal look appearing or abnormal appearing. We can kind of see that from the ultrasound. Are they large? Are they larger than normal? We would sometimes, I mean, or are there strictures in the collecting ducts? We get ultrasound, we get CT scans to kind of look into this. Sometimes we get MRIs also. All right, next slide. So when we now that we know what symptoms, of course we know they are vague. Now we know what tests to get. Now, how do we actually stage kidney disease? How do we know what stage you're in, for instance? Now, you're at home. I want you to just remember two, maybe three things on this slide. Really, there's stage one, there's stage three, and then there's stage five. Right? I think about stage one and stage two basically as the mild folks, mild kidney disease. really, we check your GFR, which, and we see that it's, around 90, or it's, between 60 and 89, you know, not very exciting. I would say, well, your kidneys are mildly, have some issues maybe, but in fact, many lab tests don't even capture that stage one and stage two levels. So, and that tells you we don't really worry much in when you're in that stage. When we start the time we start to worry is when you start to get into the stage three the stage three, and really at that point, we start to see more systemic, more electrolyte abnormalities. We start to worry more about, things like your parathyroid hormone. We start to worry about things like, your calcium levels. We start to worry about your phosphorus levels. So at stage three, that's when things start the kidneys, a lot of the nephron, you're almost halfway, like, kidney stage, almost halfway to complete failure. But and so at that point, we're beginning to kind of see the kidneys are able to compensate, but then they're getting close to halfway, back. And so we start to see more like, phosphorus is, abnormal, potassium is abnormal, calcium is abnormal. We start to see some of those things, of course, even more so into stage four. Now, I want you to remember stage five, because that's when you need, at that point, the patients are like pretty much end stage renal disease. The GFR is less than 15. They're probably getting dialysis or getting ready to be on dialysis. Now, stage four is a little different than everybody, because that's about the time when your doctors typically, if you were seeing a primary care doctor, your family medicine doctor, your internal medicine doctor, will be saying, maybe we should get you to a nephrologist, because, we're getting ready. This thing is, your kidney function is declining to the point where we might need to put you on dialysis at some point. Hopefully not, but we want a nephrologist, a kidney specialist, to begin to eyeball you a little bit closer at that point. If you don't have one already, we're trying to figure out how that would work. But again, we are very, our guards are up, once you start to really get into these advanced stages like stage 3B, stage 4, stage 5. Of course, at that point, you're pretty much getting dialysis. But so our goal is to prevent you from progressing, from where, if you're stage 3, we don't want you going past. We want you to stay in that stage 3A, if that's where you are. If you're in stage 3B, we want you to stay in that range, or but we don't want you getting worse. And so our goal is to look for what are the things you're doing, or what are the foods you're eating, how can we help you as as a clinic, to not to progress further, because I don't want to have to see you in the hospital, in end stage renal disease, and having to be getting dialysis. All right, next slide. So again, I mentioned earlier, kidney disease, many other health problems, but really, they have to do with how electrolytes move back and forth, right? And so one of the first things you begin to see in patients, especially when you get into that stage 3A level, is they develop anemia. Anemia is one of the very, very interesting findings we see. And you ask, why? Like, why would I be anemic? Because I have chronic kidney disease. Well, it's because your kidneys produce an important, hormone that helps to regulate red blood cell production. It's called EPO. And so whenever as your kidneys begin to decline, that's one of the first indicators, and we start to look for patients, they start to become more anemic. And as they get into the stage 4 levels, it's more prevalent. You see patients are anemic. Now, many times they're anemic, they're mildly anemic or moderately anemic, not bad enough that we need to replace your blood, but we need to monitor it, because again, and see if we need to maybe start replacing some of that, those factors. We need to get you to a nephrologist to start to kind of monitor that a little bit closer. We also see, phosphorus levels being off. Again, that more commonly around the stage 4 level. Your high potassium levels, starts to show up, because again, we don't want your potassium in your blood high, because bad things can happen when your potassium levels are high. But again, that's one thing. So was one of the things that we start to worry about: high potassium, low potassium. Regulation of that electrolyte. Metabolic acidosis. Why? Because your kidneys actually, in addition to all the things your kidney does, it also helps to remove acid from your blood. And it also helps to secrete, base. And so the idea is to keep things electrophysiologically neutral. But many times, because of the kidney decline, there's a lot of issues with counter regulation, and so you tend to actually, you know, keep more acid in your blood. But when your blood stays, when your metabolic acidosis, when your blood is acidic, then we start to really worry about, just that's when some of all the complications start to develop. And so we want to definitely get you to a nephrologist to help manage this. Hypocalcemia is another one, and of course elevated parathyroid hormone, because remember that hormone it helps to regulate your calcium levels, and when your kidneys help to basically regulate that. And so when your kidneys are off, then you start to the parathyroid hormones, just get off, and then now you're producing, now you're just your calcium level starts to just go sky high, and so sometimes even patients would actually need to have their parathyroid hormone taken parathyroid gland taken out, because of that just it just gets much bigger, and just the levels just get really sky high. All right, next slide. Now, of course, I alluded to this earlier, that when we start to see your kidney function decline, many times your primary care doctor can do the testing, can evaluate you, can manage you, especially if your levels are stable, or we recently identified that you don't have any abnormal, your labs are not crazy abnormal, you don't have the metabolic acidosis like I mentioned earlier in the last slide, you don't have the phosphorus problems, you don't have the calcium problems, you don't have the parathyroid levels, your parathyroid levels are good. Many times your primary care doctor can actually manage that. Now, when you start to have those electrolyte problems and you start to get more symptomatic, then that's when we start to think, maybe we should get you to a nephrologist, and that tends to happen around that stage 4 level. And so we are very careful to get you established with a nephrologist, a kidney specialist, who can then help kind of guide some of that management, kept checking some of these levels a little bit, more frequently, and helping to really keep things a little bit tighter, managing your blood pressures if you have resistant hypertension, for instance, keeping that much in a better range, and just helping partner with your primary care doctor to keep you stable, because and of course, in some patients, they still inevitably decline. At least getting ready to making sure that we have all the tools we need. Have you, make sure that you have the fistula in, so you can, potentially get the dialysis or whatever you need to get you feeling better. All right, next slide. So let's talk about a couple of cases actually. So consider a patient who has no medical condition, and has a current serum creatinine. Remember, the creatinine is actually produced in your blood, and your kidneys filter it, and that number helps us to know, like, how bad, the higher that number is, the worse your kidneys are, right? And so imagine the serum creatinine is 4, and say a month earlier the patient's creatinine was zero point 0.6. What does that mean, right? So, first things first, the patient has no medical history, so I'm not worried that the patient has diabetes or hypertension. However, the patient could be taking medications that could have caused his kidney function to decline. I mean, yeah, it's a little quite rapid, so I'd want to find out what the patient has been taking. This new supplement he's taking that is creating this problem. And also, being that the creatinine is so high, I'm curious if the patient is actually the volume status of the patient is actually good. Like, are they drinking? Are they eating? Is the patient just in a nursing home and not being neglected for for a few weeks? Those are the questions I want to know. But for sure, what we do know is that the patient is not in chronic kidney disease, based on assuming that creatinine, the zero point 0.6 number, was the patient's baseline in the past. That 4 milligram, that four number shows that it happened just very recent in the last month. So that's not chronic kidney disease. Why? Because it has to have happened. It has to be more consistent over at least 3 months, right? Over 3 months. So this patient is definitely not chronic. So the patient is likely in the acute phase, maybe subacute, but definitely acute phase. Now, most times when the job of your provider is to try to get to the bottom of why this has happened, right? If the patient is in the hospital, how can we what can we do? Do we need to hydrate the patient? Do we need to strip you of certain medications you're taking? Of course, we don't want to expose you to more contrast. We want to make sure that certain things. We want to make sure you're not taking ibuprofen and any of those NSAIDs. And so we do these things. We try to see if we can get that creatinine number back down to improve the function of your kidney. But again, I'm just showing this case study just to tell you it's not as we can tell sometimes when the patient is acute, but um you know but then there are different risk factors, that different things we have to consider. Volume status. We have to think about nutrition. We have to think about other things that could be playing a role in this number, and how to bring it down back down to normal as quickly as possible. But this is definitely not chronic kidney disease. Okay, it's just too soon. Okay, next question. Now, what about this patient who has had an identical serum creatinine of 4, and the patient has had a long-standing, poorly controlled diabetes? Interesting. And has had serum creatinine of 3.5 2 years earlier, right? As well as chronically increased albuminuria. Now, that albuminuria is basically just proteins. Basically, we talked about how when there's increased proteins in the urine, that's albumin in the urine, albuminuria, protein in urine, and that means that the kidneys are not doing as well, right? When in this patient's case, he has a long-standing history of poorly controlled type 2 diabetes, and he's had this creatinine high for 2 years ago. So it's not a new thing. Now, assuming that this 3.5 has just if it just happened recent in the last month, we'll say, okay, well, maybe it's acute. But in this case, it's been going on for 2 years. So now his number is 4. So I mean, it's definitely not acute. So we're thinking it's definitely in the chronic category because of the time frames over 3 months. But now his creatinine has gone up to 4, right? It was 3.5 2 years ago. Now it's 4. Now the question to ask is this a slowly progressing case, you know, or is this a patient that has had a recent decompensation in the kidneys, where it might actually recover back to that 3.5 level, or that same or that or 3.6 or something somewhere there. So we want to see, okay, is there something else that we could correct that could help the patient come back down to 3.5, which has been the patient's baseline the last 2 years, or are we in a new territory where, like, this kidney function is just slowly getting worse over the years. And so that's one of the things that's how we kind of juggle these numbers, and that's how we kind of think about it. But again, it's important that we test the patients, right? And that question I would have is, why has this patient not gotten any more labs in the last 2 years, right? I only have the number from 2 years ago. We don't have any information about what happened over the last, his lab from the last 6 months, or 12 months ago, to help give us more ideas. But again, in patients that have chronic kidney disease, it's a good idea to have labs done, every 3 to 6 months. That's what we kind of recommend, not waiting 2 years. This has just been a long time. And I would assume that the patient is taking, diabetic medications, because he has, diabetes. Of course, it's poorly controlled, but I would think he's probably taking some diabetic medications, which some of those can affect the kidneys. I would also assume that he's taking some blood pressure medications, given his diabetes is really advanced, is really bad. So I would expect a little bit more of a tighter, follow up, more labs done, maybe once every 6 months at the very latest in this kind of patients. Now, the patient would also benefit from probably seeing a nephrologist. At this point, the kidneys are just getting much worse. Probably a good idea. And then but then, of course, finally, knowing that this patient's condition is not reversible, like, at this point, this is chronic kidney disease that is not going to get much better, right? Much better. We're not going to see the creatinine numbers drop to 1. Well, it's always going to be, it's chronically, it's irreversibly damaged. So very likely. Okay, next slide. So how can we keep our kidneys healthy? Of course, healthy blood pressure, controlling our blood sugars. If you have diabetes, that's a big one. We talked about that nauseum today. Lifestyle active lifestyle, 30 minutes, moderate intensity, 3 times a week. Keeping a healthy body weight, obesity is not a good idea for the kidneys. Um, of course, don't smoke, limit alcohol intake. Interestingly, alcohol does kind of, it does, can damage the kidneys many times indirectly, right? Because it affects the liver. Because it affects the liver, it also inevitably also affects the kidneys. And so, very, very important to limit your alcohol intake. I know we live in a Umpqua Valley where like this is like the wine capital of one of the wine capitals except for Napa, in the country. But still important that that we're very careful, especially if you already have chronic kidney disease. Important that you try to cut down on the alcohol. I would even recommend one drink a day, honestly, in men. So keeping it to a limit. And of course, kidney friendly diet, meaning low sodium. I know, go easy on the salt. And then, of course, talking to your doctors. There might be some medications that we could place you on, to help to protect your kidneys. Actually, in diabetes, one of those medications is actually an ACE inhibitor, lisinopril, that actually helps to protect. It actually, has evidence to be protective in patients that have type 2 diabetes. Also talking to your doctors about maybe seeing a dietitian about maybe if there are any supplement that you might be taking that could be causing problems to your kidneys. Your doctor would want to know about the supplements and maybe look into them because they can be harmful. All right, next slide. So yeah, remember alcohol not good for the kidneys. This is a nice little chart of I-5 and all the different wineries we have in this area. It's quite amazing. I don't think I've been to as many, but if you have chronic kidney disease, be sure to cut down on the alcohol. Of course, I know we have a lot of nice breweries too, but I'm not really into beer. But yeah, but keep an eye on the alcohol thing. Try to cut down on that. And of course, the other slide, just good foods that are not good for you. You see that things like the tobacco, the salt, the sedentary lifestyle, all the fast foods. They're very high in all the preservatives and sodium and the fries. Try to the goal is to stay away from that all that stuff. Of course, fruits and vegetables, as you can see, because exercise. These are the water. Very good for your kidneys. Okay. Next slide. So yeah, so there's a short video I was just going to show you real quick. Sodium and your kidneys. I don't know. Can we get that played?
Sodium. You've probably heard of it. Maybe you've seen it in big letters on food packaging in the supermarket, or maybe your doctor has told you to lower the amount of sodium you take in. But what is sodium? Why does it matter? And why is that can of soup bragging about not having it? Let's learn about sodium. Sodium is found in salt, and your body needs some sodium to work the way it's supposed to. You can get sodium through foods and drinks. Your body can have too much sodium or not enough sodium, but you want just the right amount. If you have chronic kidney disease or end-stage renal disease, also known as kidney failure, it can be hard for your body to keep the right balance of not too much and not too little sodium. Why is that? Well, your kidneys are like filters that remove waste from your blood. When you have kidney disease, your kidneys are not filtering your blood as well as they should. If you have too much sodium, it's your kidneys that get rid of it. But with kidney disease, your kidneys may struggle to filter out the extra sodium. This causes your blood pressure to go up. High blood pressure can damage your blood vessels, your heart, and even your brain. It also increases your chance of having a stroke. Too much sodium can also cause you to feel very thirsty, to have swelling in your legs, feet, or face, and to feel like it's hard to breathe. The good news is that you can help your body have the right amount of sodium and lower your chance of having high blood pressure. How? Start by lowering how much sodium you take in through food and drinks. Limit salty snacks like chips and pretzels. Try snacking on no salt added snacks apple slices, or baby carrots. Upping your veggie intake is always a good idea. Use fresh or frozen vegetables instead of canned, which can be high in sodium too. Some foods, like frozen meals, fast food, and canned soups, can be shockingly high in sodium. Even foods that don't really taste salty can have surprising amounts, such as cheese, lunch meats, and even cereal and bread. Bottom line, check the nutrition label on all packaged foods you eat and look for low or reduced sodium options. A good general rule is to eat and drink less than 2,300 milligrams a day. When cooking at home, herbs and spices can add major flavor to all your favorites instead of salt. You can even find sodium-free seasoning mixes. For drinks, think more water and less soda in sports drinks, which have added sodium. Talk to your doctor or dietitian about how much sodium is the right amount for you.
All right. All right. So yes, so that's the summary. Talking to your dietitian, talking to your doctor, talking to your PA or your nurse practitioner about figuring out what foods you should be eating. What if you have questions about that, let's look at the next slide actually. All right. So you have foods that good for your kidneys. You have the dark berries, the blueberries, raspberries, strawberries, cauliflower, the olive oil, pretty good, garlic, bell peppers, pretty good, rich in vitamins and C and A, cabbage, skinless chicken, because it has less potassium and sodium than when you have the skin on. Regular and other green leafy vegetables, they're low in potassium, they're full of vitamins, they help lower blood pressures. Cranberries help prevent, of course, UTIs also, and then red grapes good for your kidneys too. Uh, Apples reduce cholesterol. Pineapples also very good for you. Okay. All right. Next slide. So yeah, so potassium is another electrolyte. Is another element that we have to keep in a very tight balance. Like I mentioned earlier, really high potassium can cause problems, right? Very low potassium can also cause problems. So you have to keep it at a healthy range. Foods that have low potassium, in patients that already have high potassium levels, you think about apples, cranberries, grapes, pineapple, and strawberries. But if you have low potassium and you're trying to get the potassium up without being on the on potassium supplementation, then you might think of avocados, bananas, melons, oranges, prunes, raisins, and the same thing goes with cauliflower versus artichokes. Low in patients that think if you need low potassium foods, you're thinking cauliflower. High potassium, you're thinking artichokes, onions, peppers versus winter's plantains, spinach. So we kind of there it's kind of contrast, and it contrasts what is high and what is low in potassium. Beef and chicken, low in potassium. Beans, high in potassium. White rice, low in potassium. Brown rice or wild rice, high in potassium. So something to think about. All right. And same thing with phosphorus. Phosphorus is another one that we have to keep in very tight regulation. So, if you think about your breads, of course, I don't really recommend breads as much, but if you were to eat bread, if you're gonna go for more low phosphorus containing foods, you're thinking of the Italian, French, and the sourdough bread versus the whole grain bread in pretty high in potassium, in phosphorus. Your corn or rice cereals versus your bran cereals, when it comes to low and high potassium. Cream of wheat has low phosphorus levels. And then oatmeal, high phosphorus levels. Unsalted popcorn, the same thing. Nuts and sunflower seeds, high, high phosphorus foods. But again, we try to avoid those high phosphorus foods. So, just kind of look at that. Just try to avoid those things. If you're especially if your phosphorus is really high. All right. And tips for limiting fluid intake. We want to, of course, drink from a small cup. Try to, especially in patients, if you notice that your kidney function has declined into the stage 4, stage 5 range, you don't want to be taking in too much volume, because patients that are already on dialysis, we try to pull volume, not let you have more, a lot more. So you gotta limit your fluid intake, limit your sodium, because the salt, whenever you have salt, water always follows. So, kind of cut down on that salt, and then your fluid, you can regulate your fluid better. Cut back on the foods that have high water content, like ice cream, soups, fruits and vegetables, some fruits and vegetables. And then, when you feel thirsty, what do? You suck a piece of ice, mints, chew gum, things to prevent you from having to just crave, just, you know, ingest the fluid. So yeah, cut down on those. All right. So in summary, important to work with your doctor, dietitian, to keep your kidneys as healthy, so that you don't, you don't, so your CKD does not, even if you have CKD, it does not progress to where you need to be on dialysis. Because when you get to end stage renal disease, that's kidney failure. And at that point, you're going to require regular hemodialysis, and it's just not as fun. And in fact, life expectancy goes down a lot. So, very important that you keep your kidney disease stable. That's a funny picture I put up there. I think, yeah, dialysis is not, it's not fun. So let's try to stay away from having to get to that point. And our job is to help you keep your levels controlled, see your primary care doctor, to have your labs checked, and talk about these numbers, and ask questions. Okay, because an informed patient is a great patient. Is a patient that is on board with what we are doing. And I will open the floor to questions at this point.
Okay. All right. Thank you, Dr. Okenye. So I have this review slide, and then also I thought there was
Yes, yeah.
just for those people that want to
Look it up. Yeah.
Yeah. Double check your stuff, I guess there. Which again, you just said an informed patient is a good patient, right?
Exactly.
All right. Well, a couple of questions for you. First one, you mentioned contrasts early on. What is that again?
So whenever patients have to get certain types of imaging, like CT scans, MRIs, sometimes we want to get better visibility of the organs, of the structures we're looking at, and many times we will inject the patients with contrast. And contrast basically just makes the organ light up better. Basically, it just helps improve visibility and helps you see what you're looking at. As a radiologist, as a doctor, you want to see better, basically. And there are certain diseases that you don't really see as well without injecting contrast. And so however, sometimes that can hurt the kidneys a little bit. There's been some talk about contrast-induced nephropathy. It's not really a thing anymore as much. We think if patients can do fine if they just hydrate, prior to them getting contrast, but it can hurt the kidneys, and so we try to limit those in patients that have chronic kidney disease, especially the worst stages.
I understand now on the context of the contrast. In other words, yeah, it shows up brighter on the
exactly.
Right?
Exactly.
The other last question I have for you is about recovery. I'm always amazed at how well the body can recover if you give it a chance. So some of the things that you've talked about today, I'm failing at: diet, too much sodium, lots of things. If you are able to make some corrections, can you just talk about what you've seen as far as how well the body will respond if you make adjustments? And it may or may not, maybe the damage or maybe the things that happen to the kidney are permanent and they're not going to get reversed or get better. But can you encourage us a little bit if you did make a change today because you could see that there was a problem? Will the kidneys respond?
Yes, and now, of course, chronic kidney disease, it will not get worse. That's the guarantee. Like there's less chance it will get worse with chronic kidney disease, because again, remember, it's chronic, right? In this context, now, because as I mentioned earlier, you can have some acute decompensation where, like, it kind of momentarily, because of something you're doing, even though your kidneys have already declined, they can decline even more. And the goal is to get you back to that baseline that your kidneys have already now established, and make sure it doesn't get worse. And so, things that we can do, simple things like exercise, losing weight. I know it might not sound like a big deal, but remember, it affects, if you're diabetic, you can get your numbers better that way by eating better, exercise, and in doing so, you can reduce your chances of more damage to the kidneys, by the sugars. Controlling your blood pressure. How do you do that? Well, if you eat like low sodium diet, for instance, or you cut off the fries, cut off the salty crackers, and cut off the canned foods. I know it's hard, in these times, and sometimes those foods actually are not are also as expensive, and so we cut those things off, and then you improve your blood pressure because you've improved your blood pressure. Now your kidneys have a little bit more room to breathe. So there are some very simple lifestyle things that we can do, and it's those little things that actually honestly make the big difference. Because remember, chronic kidney disease is not common in patients that are very young. It's usually patients that as we get older. So remember, as we get older, just more mileage on the kidneys, just like that car that has 150,000 miles. You gotta watch that car a little bit carefully, you gotta do a little more TLC with the car. So the same thing with the human body. You a little bit more gentle, a little bit more, a little bit, watch things a little more careful as we get into that 50, 60 range, where we tend to see chronic kidney disease.
I heard somebody say one time, it's not the first 50,000 miles, it's the second 50,000 miles.
Exactly.
Terrific. Any final thoughts for today's Evergreen Talks?
No. I just want to say thank you to all the patients that we have, and all our wonderful patients that make Evergreen what it is, and they're very, just very, they're just hungry for knowledge. We just want to learn and want to know, and are very attentive to their health. I've seen some of the best patients here on the West Coast. And I think it's just awesome when you have patients that are invested, in getting in taking control of their health, and yeah, it makes for a great time.
Terrific. All right. Well, thank you for all that knowledge and for that information today.
Yeah. Thanks, Brian.
You can visit evergreenfamilymedicine.com for more information, and join us for Evergreen Talks the second Thursday of every month at 4:00, a monthly Facebook Live and YouTube Live event, by the way, where our physicians and providers and specialists present topics that matter to you. Dr. Okenye, I hope you have a good afternoon.
Thank you. Thank you, Brian.